is a senior consultant of radiation oncology at Paras Health, Gurugram. Ma'am, welcome to the show.
Good evening.
We also welcome Dr. Ajeev Mishra, who is consultant nuclear medicine of nuclear medicine at Paras Health, Gurugram. Sir, we welcome you to the show.
Thank you and good evening, everyone.
Good evening, all. With all our expert panelists here with us who are expert in medical oncology, urology, radiation oncology, as well as nuclear medicine, this discussion will give a very good, well-rounded input as to what prostate cancer is and everything that you should be knowing. So let us start our first question covering the basic aspects around prostate cancer with Dr. Jyoti. Ma'am, can you please explain us what prostate cancer is, as the audience is from both medical and non-medical background? So keeping the language very simple and also explaining them the different stages of prostate cancer and how it varies with the treatment options.
Right. So prostate cancer is the cancer of an organ called prostate. So prostate is a gland situated at base of the urinary bladder, right? So like many other cancers, this cancer is also staged to decide the best possible treatment because the treatments are stage dependent. So for prostate cancer, like many other cancers, we have a system of staging called TNM staging, wherein T stands for the tumor in the prostate gland, N stands for the nodal status, the regional lymph nodes, whether they are involved or not, and M stands for metastasis, wherein we see whether the disease has spread to other organs or not. So prostate cancer is peculiar because besides this TNM staging, we also take into consideration the grade group as per the biopsy of the prostate lesion biopsy. And also we take into consideration the serum PSA levels, which is a tumor marker for prostate gland. So based on a combination of this TNM staging, the grade group on the biopsy and the serum PSA levels, we ultimately allot a stage to a patient. So stage 1, if I try to simplify it for the audience, stage 1 would mean that the disease is limited to the prostate, that grade group is low, less than 6, and serum prostate is less, PSA level is less than 10. When we move to stage 2, the disease is still limited to the prostate, but now the PSA level is more, it's less than 20, and the Gleason score, as we call on the biopsy, is less than 8. Stage 3 means that the disease now has spread outside the prostate to its outer layer or to a surrounding structure called seminal vesicles. And stage 4 obviously means that the disease has spread to the lymph nodes or other organs. So stage 4 is the most advanced stage. Now, why is it important to stage? Because as I said earlier, the treatment decisions are made as per the stage of the disease. And we know that there are different treatment options. For localized disease, we have local treatments in form of surgery and radiotherapy, including brachytherapy. And for more advanced stage, we have hormone therapy, we have chemotherapy, immunotherapy, and targeted therapies. So it's very important to stage the prostate cancer correctly and then base our decisions on that staging.
Thank you so much, ma'am. You explained us very nicely all these different things. We would also want to know from you that early detection into any cancer screening is very important. It is said that the earlier you detect, the more chances of survival there is, as you can treat the cancer at the very early stages itself. So for our audience, for them to understand, what are the early signs and symptoms of prostate cancer, if you can also help us understand that.
So see, the symptoms would depend on the extent of the disease, right? So early on, the patient presents with non-specific urinary symptoms. So obstructive uropathy, that is what we call, that the patient has the urge to pass urine more often. Patient gets up in the night, what we call nocturia, often repeatedly to pass urine. There could also be episodes of acute retention wherein the patient is unable to pass any urine. And sometimes that may be the presenting symptom wherein the patient presents to the emergency with total inability to pass urine and may require catheterization. Otherwise, with more advanced stages wherein the disease has spread to the other parts of the body, then the symptoms will depend on as to where they have spread. So suppose the prostate cancer has spread to the surrounding structure, which is the urinary bladder, which is the closest to it. So then the patient may have passage of blood in the urine or semen. And there may also be urge incontinence, or patient has the desire to urinate but is not actually able to pass it. Furthermore, more advanced it gets, if it enters the bowel, the rectum, there could be constipation or bleeding per rectum. If it spreads to other body parts like bones, patient may have bone pains, backache. If it spreads to lung, then patient may have difficulty in breathing or cough. And some non-specific symptoms like loss of appetite and weight are often associated with advanced stage. Now, as you said, the key to surviving cancer or winning the cancer is early detection. So it's very important that people are aware of all these symptoms, and at the onset of any of these symptoms, they should seek medical advice. So the first point of contact could in fact be the urologist, wherein they would examine the patient, they would conduct some simple test, maybe a blood test, the tumor marker PSA, may order subsequent tests like MRI, etc., and then plan the treatment. So it's very important not to be sitting at home with presence of any of these suggestive symptoms. Seek medical attention immediately and go to your doctor.
Thank you so much, Dr. Jyoti. And for giving us more understanding on the urology aspect, we have Dr. Anurag Khaitan with us. So, sir, we request you to kindly take forward what Dr. Jyoti was sharing, that if a person is suspected of prostate cancer, what different diagnostic tests would you suggest and how would the treatment go about, so that our audience is made aware the entire process, how it goes?
Nowadays, most of the prostatic cancer which are detected in early stage are those who have been basically asymptomatic or minimally symptomatic, and they just come for health checkup and we examine them and do the routine test and the PSA comes out positive. Because once the symptoms starts appearing, then usually the disease is in the advanced stage. So my recommendation for the general public is, if you are more than 55 years old, then you must get your prostatic examined by the urologist and get your PSA and some basic other ultrasound and urine routine test. And if you have a family history, like your brother or father is having tumor, then you should go to doctor early, around 50 years of age, and get these tests. And the first test is the basically PSA test, which gives the indication. Distal rectal examination is the integral part of the patient examination, and history taking is another important aspect. And after this, we go for multiparametric MRI, because this has more sensitivity and accuracy as compared to rest of the tests. And if that also shows high index of suspicion, in those cases, we do transrectal biopsy of the prostate under ultrasound guidance. And once the disease is confirmed, then further tests are done to stage the disease. If the patient is having cancer, then we do nowadays very good investigation like PSMA, PET scan is available. So if the availability is there, we directly go for that to stage the disease. Whether it is a localized cancer or it is an advanced metastatic cancer or locally advanced cancer, that we can diagnose.
Thank you so much, Dr. Khaitan. So we spoke about what prostate cancer is, its different signs and symptoms. Also, we discussed the different diagnostic methods. Before moving on to and elaborating more on the treatment aspect, I have one question for Dr. Ajeev Mishra. Sir, could you please help us understand the role of nuclear medicine in diagnosing and staging of prostate cancer, and how does it complement other diagnostic modalities that are there?
Yes, thank you. So basically, nuclear medicine has many things to offer in prostate cancer disease. So basically, let's talk about diagnostic things. So diagnostic, conventionally, bone scan is being more frequently used to diagnose the bone metastasis. And so sclerotic lesions are the main component of metastasis in prostate cancer, and bone scan was frequently being used to diagnose it with good sensitivity around 80%. However, specificity was relatively lower because of various benign pathology simulating metastasis. So, further development happened, and PET tracers with bone seeking abilities were developed, and then still the sensitivity was increased, but specificity thing was still not improved because of, again, false positive uptake by various benign pathologies, fractures like Paget's disease, some osteoid several other benign pathologies. So then further improvement happened, and now we are in the era of PSMA PET imaging, which is basically targeting the targeting at the molecular or receptor level. So even in the there is no anatomical manifestations in the form of cortical damage or cortical sclerosis or any significant radiological enlargement of lymph nodes. Before that, we are able to pick up the lesions, and it is so PSMA PET CT is being frequently used for staging of prostate cancer. It has a very limited role in the diagnosis, as most of the time it is these patients come to us with already proven malignancy. So further there is a role of N-stage detection, that means nodal status detection and bone lesion detection. So it has very good sensitivity and specificity for those lesions. So it is almost it has potential to change management in up to around 30% of the cases than the previously used conventional imaging methods, conventional staging methods like CT scan and bone scan. Yes.
Thank you so much, Dr. Ajib. We will come back to you later to understand further. But let us move on to the different treatment aspects. Radiation therapy has been long seen, or chemotherapy as it is also called, has been seen in different cancers as well as including prostate cancer. So my next question is to Dr. Aditi Agrawal. Ma'am, can you please explain us the role of radiation therapy in the management of prostate cancer so that our audience is able to better relate and understand it? And also, how does it differ from other treatment options? And does this therapy generally varies for different age groups if you are detected with prostate cancer at different ages?
So when we talk of radiation, first of all, the most important thing to understand is that radiation is a local therapy. That means it has its effects as well as side effects in the area where we are giving radiation. So for prostate cancer, we will be giving radiation to the area of prostate, surrounding organs, and whenever required, the nodal areas. So the effects will be in the area of the pelvis, on the prostate, on the urinary bladder, on the rectum, and definitely on the cancer. It is not like chemotherapy, which is a systemic therapy in the form of either injections or tablets, which has an effect over the entire body. So systemic therapy has its own role when we want to target the disease present anywhere in the body, whereas radiation is done when we want to target the local disease at that particular place. Now, radiation therapy for prostate cancer has a very important role, be it any stage, be it localized, be it locally advanced, or be it metastatic. How does it act? It acts by causing cell kill. It actually causes the damage of DNA, which is the genetic material inside the cell. So the cell is unable to multiply. And that is how the cells would eventually die. So if I compare it with surgery, which people would understand better. With the surgery, we remove that tumor outside the body by going in, be it by an open surgery, by a laparoscope or a robo. But when we do radiation, we do not go inside the body physically. The rays penetrate and they cause cell kill. The cells would eventually die. And that is how the tumor regresses. And we see response on our scans, we see response in PSA. Now, for localized prostate cancer, we can do something called brachytherapy, which is a form of internal radiation. The indications are very limited because, as Dr. Anurag was also mentioning, that we very less commonly get early cancers which are screen detected. So the patients who are eligible for brachytherapy are far less than what are eligible for external beam radiation therapy. The most commonly used radiation is external beam radiation therapy, which is done with the help of a machine called linear accelerator. So this machine again focuses the disease inside the pelvis, that is the prostate and surrounding organs. Whether we treat the nodes or not is dependent on the stage, the risk stratification, as Dr. Jyoti had mentioned, whether the patient is intermediate risk or high risk or very high risk. Radiation is different from other therapies, which is mostly different from surgery in the form of being non-invasive, painless, and being done on an OPD basis. The patient does not require any admission to the hospital. It is different from chemotherapy or hormonal therapy or any other systemic therapy by being a local therapy. Now, radiation for different age groups. Usually age is not the criteria. The criteria is the risk stratification, whether the patient is low risk, intermediate risk, high risk, or very high risk. Age comes into play when we want to make a decision as to whether we want to treat the patient or not, whether the patient would be able to tolerate that kind of therapy or not. And it is not necessarily the chronological age, it is the biological age, which means the patient's performance status is equally important. A person of 65 years may not be as fit as another 75-year-old who is very active without any comorbidities. So it is not just the numerical age that is important. We have to look at the patient in totality. What are the other comorbidities? What is the activity status? What is the performance status? And sometimes we use certain tools for geriatric assessment, that is for elderly population, because mostly prostate cancer is a disease of aging population.
Thank you so much, ma'am, for clearing us all those queries. And as rightly said, that number is not as important as evaluating the entire health of the person is important. So before moving on to further different therapies that you highlighted and the surgical procedures, the next question is to Dr. Jyoti. Ma'am, can you please help us understand what the basic treatment and different kinds of treatments that are available? Through Dr. Aditi, we understood about radiation therapy and the difference between it and the systemic therapy. But what other different treatment aspects are involved around prostate cancer? Can you please help us?
Yeah, so prostate cancer involves a team of specialists. So it's not just a domain of urologists or the surgical oncologist, but a team effort wherein we include medical oncologists, radiation oncologists, the urologist, and other nuclear medicine expert like Dr. Ajiv, the pathologist who would report it, and now molecular oncologist as well. So it's a team effort wherein everybody puts in their inputs, and then we decide the best possible treatment options. So as I said, treatment decisions are based on the stage of the disease, the risk stratification of the disease, patient's condition, the fitness level or the performance status, whether or not the patient suffers from other ailments or not, like diabetes, heart disease, hypertension, etc., neurological issues. So we have to take into consideration all those factors when we sit down to make the treatment planning of a given patient. So treatments, as I said, are surgery, radiotherapy, both of these being local treatments. Then the treatment could be systemic treatment, wherein we do something which goes into the blood, and therefore that involves its effect on various body parts, not only prostate gland. It would go and work on the lymph nodes and all these sites which may be affected with the cancer. If you want me to talk about medical treatments right now.
Yes,
Yeah.
please.
So in terms of, since I'm a medical oncologist who would treat prostate cancer with various types of medical treatments, I want to tell the audience that a lot of advances have now happened in terms of medical treatments over the past many years as a result of active research. So earlier on, and for many years, and even now, the androgen deprivation therapy remains the main backbone of the prostate cancer treatment. We know that this cancer is hormone dependent, hormone driven, androgen driven cancer. And therefore, androgen deprivation is the cornerstone of the treatment, right? But in addition to that, we have various other medical treatments like chemotherapy. So we have had chemotherapy drugs available to us for many years. And there have been improvements in terms of providing supportive care to these patients who are on chemotherapy. Besides that, we have oral anti-androgen agents, the hormonal agents, and we have quite a few of them. We have had earlier abiraterone, enzalutamide kind of drugs, but we now have even newer anti-androgen therapies which are even more efficacious, like apalutamide, darolutamide, which are even better. Now, in terms of further advances, we have specific targeted therapies. So Dr. Aditi was referring to this when she said that for those patients who have some deficiency in the DNA repair mechanisms, that the body cannot repair the DNA deficiencies or the damages, then we can use targeted drugs called PARP inhibitors, olaparib and rucaparib, talazoparib. We have those newer, fancier drugs, and they definitely work better in that subset of patients. And the audience might have read in paper also that immunotherapy is the thing, the newest kid on the block, wherein we harness the power of our own immune system to fight the cancer. So these are other advances which have happened, the immunotherapy drugs, the dendritic cell therapy, the checkpoint inhibitors, pembrolizumab, and others. We are also using a combination of all these. So various drug combinations are now being explored and used for treatment, like combination of chemotherapy with anti-androgens, combination of anti-androgens and PARP inhibitors. So these combinations are working even better than any of these single drugs alone. So a lot of advances have happened, and we take more and more help from our nuclear physicists like Dr. Ajiv, wherein we are also using radiopharmaceuticals and PSMA-based targeted radiotherapy also, which is much more targeted, much more effective in terms of tumor control. So a lot of advances happening, and therefore I want to emphasize to the audience that come at right time, avail the right facilities, come to the right doctor, come to the right center for getting the effective and the best possible treatment. There's a lot of hope, and the survival, the patients are living much longer and much better.
Thank you so much, Dr. Jyoti, for such an elaborate explanation. Thank you. I would want to know from Dr. Anurag next. Sir, can you please help us highlight the different surgical options that are available for prostate cancer treatment? And people are also curious to know that how do you determine which option is most suitable for the patient? How does that process go?
In surgical options, there are two types of therapy. One is the radical treatment of the prostate when the disease is in the localized stage, and the other is palliative surgical option. In palliative surgical options, when the patient come in advanced stage, one is the ADT therapy when we remove the testes, this is surgical castration, and the other is if the patient is on some therapy and the therapies.
I believe there is a network issue at Dr. Anurag's end. Until he joins back, my next question is to Dr. Ajiv. Sir, can you also explain us the concept of yes, I believe we have Dr. Anurag back. Sir, are you able to hear us? You're on mute. Sir, please unmute yourself.
Yes. Can you hear me now?
Yes, sir.
Yes.
Please continue.
Patient come at the stage when we can do the radical treatment, there are options of surgical removal of the prostate. Conventionally, it used to be suprapubic radical prostatectomy, which requirement is very less these days because of availability of minimally invasive treatment. The various options in minimally invasive treatment is laparoscopic radical prostatectomy, robotic radical prostatectomy, and perineal robotic prostatectomy. So every procedure have an advantage and disadvantage. Now coming first to the robotic, it is a minimally invasive. The recovery is fast. The procedure is good because of magnification and 3D surgical options. But the only negative thing is the cost and the availability. It may not be available at every place. It's only available in tertiary care hospitals. Now coming to the laparoscopic, this is easily available in most of the places, and the patient, the surgeon is conversant with this, then he can do the equivalent job, because in all the surgical options, the ultimate and oncological results are same, and the complications are almost same, but the recovery and the technique differs. Now, when the patient, the third option is radical perineal prostatectomy. Sometimes the anatomy is like that, the patient had multiple abdominal operations, or if is very obese, when we cannot do this laparoscopic or robotic prostatectomy, then perineal radical prostatectomy can be done. It has the added advantage that the precision of anastomosis is very good, the blood loss is very less with the radical perineal prostatectomy, and the continence rate is quite good with this. Now coming to the palliative treatment, in this I already told that for hormonal treatment we can do surgical castration, and if the patient is on radiotherapy or palliative hormonal therapy, if the patient is still having obstruction of the urine and if he is going into the retention, we can do PUR channeling. So these are the surgical options at the various stages of the disease.
Thank you so much, sir. We will come back to you to understand more. But I have my next question for Dr. Ajeeb. Sir, can you please explain the concept of prostate-specific membrane antigen, PSMA, imaging and its significance in prostate cancer management?
So basically, PSMA, prostate-specific membrane antigen, is expressed in the normal prostate cancer cells. However, it is overexpressed. So that overexpression may be 100 or 1,000 times. So and this is the basis of diagnostic as well as therapeutic imaging. So basically, PSMA is a transmembrane protein glycopeptide, which has extracellular and intracellular as well as intracellular domain. So most of the compounds are developed to target those extracellular as well as intracellular domains, and most of the successful candidates are extracellular, targeted by extracellular, at the extracellular domains. So PSMA expression is not affected by any previous treatment. It is there is no flare phenomenon. You can see once you started treatment, you wanted to see response, then there is no flare phenomenon, which you can see on the bone scan imaging if you have treated the patient with chemotherapeutic agent or bone protective agents. This PSMA receptor makes is the most potential target where we can develop compound, and that compound will target that receptor. So some of the commonly developed compounds are lutetium based. Lutetium is a radioisotope which is tagged with some compound and targeted towards those receptors. Lutetium-177 PSMA therapy we call. Similarly, alpha therapy in the form of actinium-225 actinium-225 PSMA has also been developed. Similarly, statin-based bismuth 213, several other alpha agents and beta agents have been developed. So basically, the purpose of these compounds are to selectively target the tumor cells and with minimal effect on the background tissues. So lutetium has a slightly bigger range, so it tends to kill. So once you tag it with PSMA, so it will reach the skeletal lesions as well as visceral metastasis or nodal metastasis, and it will kill those lesions on the basis of its radiation effect. So radiation based DNA damage and tumor cell killing. That's how it helps to decrease PSMA, PSA, serum PSA level, and it helps in if bone metastasis is then it helps in bone pain palliation, and at the same time it helps to decrease the disease burden. So, but there are certain prerequisites you have to consider before starting this therapy. So, the lesion has to have adequate uptake on PSMA PET CT scan. If the uptake 90% of the time the uptake will be there, however, in 10% of the prostate cancer cases there will be no uptake. So you cannot push those patients for radiopeptide therapy. So these in those cases other alternatives should be used. However, the 90%, which is the bulk of the prostate cancer cases, where you can use lutetium PSMA therapy or actinium, both are available in India. However, lutetium based tracers are more commonly used by the people because of cost related thing, because it is relatively cheaper than alpha therapeutic agent. However, lutetium PSMA therapy has slightly more side effect than alpha agents, because alpha has very shorter range in the tissues. I mean, in the so once it reaches the tumor, then it helps in effective killing of the tumor cells without much harming the background tissues. However, lutetium tracers, it has got slightly bigger range in the millimeter range, so it will also reach the surrounding tissues, and hence it will create some side effect. So some side effects may be in the form of some severe side effect, may be in the form of renal dysfunction or bone marrow related like bone marrow related effects, like patient might have anemia or thrombocytopenia or decrease in WBC count. But most of the time these with lutetium therapy or alpha therapy, these side effects are grade 3, which we call is seen in less than 10% of the time. 90% of the time it is either mild or moderate side effects, so which is easily controlled by clinicians.
Thank you so much, Dr. Ajib. So, Dr. Aditi, as Dr. Ajib was discussing about the different side effects around those kind of therapies. So, it is generally seen that, this has been portrayed in Indian cinema and around, that radiation therapy usually causes hair loss and multitude of different side effects that we see. And this has been a common notion amongst people, that they fear getting treatments or radiation therapies per se specifically, because they feel that the side effects would outweigh the results. So we would want to know from you, are there any side effects or long-term consequences associated with radiation therapy for prostate cancer patients? And if you can help us or share some advice for the audience so that such myths are cleared out.
Right. So that was a very nice question. We keep facing this issue on a daily basis in the OPD. As you said, that whenever radiation is going on, it is not just a misconception amongst patients and family members, but also amongst general physicians who do not know much about radiation, that any side effect is attributed to the radiation going on anywhere in the body. So my first statement was radiation is a local therapy. So it would have its effects and side effects only in the area where we are giving radiation to. So a person having hair loss on the scalp, it is absolutely not related to radiation that is happening in the pelvis. That means the area below our waist where the prostate, bladder, and rectum is. So the side effects in prostate radiation would be related to urinary bladder, it would be related to the rectum, and sometimes it may be related to the small intestine. Now, in cases of metastatic prostate cancer, we have now started doing radiation. So very selected patients who have low burden disease and where we feel that the patient can be treated with a curative intent, we target the metastatic site also. That means if the patient has a prostate cancer and there is limited disease in one or two or say three bones in the body elsewhere, maybe upper back or lower back, then we target that bone also. So then in that case, the side effect would happen in the area where that bone is. So in upper back, it may cause some radiation going to the food pipe, so symptoms related to that. In lower back, it may again go to the small intestine, so some symptoms according to that. Now, what are those symptoms? Those symptoms could be urinary frequency, it could be urinary urgency, it could be hesitancy, the lower urinary tract symptoms, but they are usually temporary. They start around second week, third week in the conventional kind of radiation, which happens for 5 weeks. And they would stay till the end of 5 weeks. And in another 3 to 4 weeks, they would settle. Okay. Likewise, for the rectum, it could be tenesmus. That means a feeling of going to empty the bowel, but actually no passage of motion happens. There could be burning while passing motion, but that again is temporary and it goes away after radiation is over. One very important point here that I want to highlight is that technology has very beautifully advanced over the past few years. So we are very confident in our imaging. We know what we are seeing. We know where radiation is being targeted. We have good immobilization devices. That means we can immobilize the body so the radiation is going precisely to the point where we are targeting. Now, prostate is bounded anteriorly by the urinary bladder. In the front, there is urinary bladder, and on the back, there is rectum. So, there is a constant change in the position of prostate because of the change in the filling of urinary bladder and the filling of the rectum. That also is taken care of with the help of a tool called online imaging that we do with cone beam CT. So, when the patient is on couch, before every treatment, we take an imaging to confirm the bladder has similar amount of urine, the rectum is in a similar kind of a position, so that the prostate is in a similar kind of anatomy and it is treated likewise on a daily basis in the same fashion. Whenever we feel that the bladder is not so full or the rectum is more full, there is gas or fecal matter, we tell the patient to move out of the couch. The patient is not treated at that instance. And then again, a protocol is repeated so as to deliver accurate radiation. Now, this has helped us in reducing the side effects that happen to the bladder and rectum. Plus, the machine and the technology has helped us to make the radiation treatment shorter. So previously, we were using regimes of 7 weeks, where the patient used to come to the hospital for 35 or 37 sittings. Now the regime is much shorter, where we are able to complete this treatment within 5 weeks. That is for the locally advanced disease. For cases which are localized, for cases which are metastatic, where a very small lesion needs to be treated, this radiation can be completed in 5 sittings, 7 sittings, depending on the location, depending on the volume of disease. So technology has really helped us in making treatment much more accurate and making us much more confident, and it has definitely helped us in reducing the side effects. So if a patient comes to me today and says that I'm scared of the side effects, actually the side effects are minimal. I have even 82, 83-year-old patients who have tolerated radiation comfortably. They are now disease free after 2 years, 3 years of radiation as well. So any age group can tolerate this treatment very easily, depending on what the patient's fitness is and how the decision has been taken.
Thank you so much, ma'am, for clearing our doubts and also enlightening us with the different advances that are now available in this treatment. So, before discussing the advancements with other specialists, there is one question that we would want to ask to Dr. Anurag. Sir, can you please help us explain the concept of nerve sparing surgery? What does that mean? And in relation to prostate cancer, and how does it impact the quality of life for patients?
Whenever the disease is localized and nerve bundles are not involved, we try to preserve the nerves, because it has been found in various studies that recovery of continence as well as for recovery of erection in the patient is better if we spare the nerves. And in most of the patients, we can very well spare both the sides. And even if it is not possible to save both the sides, we can, even if we save one side also, that also makes a difference.
Thank you so much, sir. And starting on to the very last segment of this discussion, which is advancements. As there is continuous research in the study of cancer, and every couple of years we're coming out with different techniques or different styles or different therapies to combat cancer, different kinds of cancers. We would like to know some latest advances in this field of prostate cancer as well. So continuing with Dr. Anurag, sir, are there any emerging minimally invasive or robotic assisted techniques for prostate cancer? You have shared few before with us, but if you could highlight us some of the studies or techniques that are emerging that you find promising or that you hope in future would be very good, if you would want to share those.
Yes, the nerve sparing is one of them. The other is single port robotic radical prostatectomy. This is also coming up in a big way. The incisions, they decrease, and even with a single port we can do the surgery. The third is robotic perineal prostatectomy is also being done nowadays. The third is we integrate the preoperative imaging, and that we feed system while doing robotic prostatectomy, that helps in sparing the nerves and do more precise. So these are one of the few recent advances in radical prostatectomy.
Thank you so much. Coming on to Dr. Jyoti, ma'am, same question for you. Are there any new advancements in medical oncology for prostate cancer treatment that you would like to highlight?
Yeah, so I think I've already answered this earlier, but I would want to re-emphasize a few of the things that medical treatment have really advanced really well. They have led to improvements in overall survival also. Patients are leading a much better quality of life as well because of these refinements in the treatment. We have newer drugs. We have newer hormonal agents, newer anti-androgen drugs. We have newer targeted treatments which work for a specific subset of patients, the PARP inhibitors, as I mentioned. We have immunotherapies come in big way. Again, they make the use of our own body's own immune cells, the lymphocytes, which then go and identify cancer cells as foreign antigens and kill them. So very effective treatments there with immune checkpoint inhibitors. We also have a combination of these treatments working really well towards improving the response rates and the survival of these patients. And various other drugs, like there is a lot of research going on still in terms of refinements in immunotherapy in form of cancer vaccines. That's another new thing. Newer radiopharmaceuticals, which are coming up in a big way. So a lot of action happening there. We are practicing. I'm sure other team members would agree that we are practicing in very exciting times. There's a lot of scope, a lot of advancement happening, and we expect the results to improve even further because the research is still ongoing, not only for surgery, radiotherapy, medical treatments, but various other modalities also.
Thank you so much, ma'am. Same question to Dr. Ajib. Sir, are there any novel nuclear medicine approaches or therapies under investigation for prostate cancer that you find interesting and then you would want to highlight?
So currently, so I have explained many things, but currently, so it is very difficult to replace PSMA based something. I mean. By PSMA therapy. So it is already very popular and very specific to the prostate cancer patient. And we are here selectively targeting the tumor cells without having any reasonable or maximum side effect to the surrounding tissues. So, but several trials are going on, and in the preliminary trials, it has even lutetium PSMA therapy has shown survival benefit over the chemotherapeutic agents, and with lesser side effect than the chemotherapeutic agent, especially in the CRPC, castration-resistant prostate cancer patient, which is around 15 to 40% of the time. And some of the studies are also going on side by side with the help of radioligands and the alternate therapy like androgen deprivation therapy. So we are side by side also focusing both the therapy at the same time with minimizing side effect. However, some of the time when you combine these two therapies, radiopeptide therapy as well as androgen deprivation therapy, then there are chances of bone weakening. But again, some agents are there to enhance the, quality. Increase the, decrease the osteoclastic activity. That means bone resorption process, and enhance the strength of the bone. So various trials are going on, and let's hope in near future we can combine internal radiation therapy, that means with the help of radioisotope, along with some other treatment which are medically used by the clinicians.
Thank you so much, sir, for highlighting that. Same question to Dr. Aditi, ma'am. You have discussed extensively the different therapies that are there. Can you highlight some advances or new techniques that are there in radiation therapy that have improved the outcomes, or that you are hopeful for that would do in the future?
So first of all, as I mentioned, that because of the advancement in technology, now we are able to deliver radiation more precisely. So we are able to do high dose radiation in a single sitting. So there is a multitude of radiation regimes that are available depending on the size of the prostate, depending on the risk stratification of the patient. We have shifted from the 7 weeks conventional radiation to the 5 weeks one for the high risk ones. For the localized ones, apart from brachytherapy, we are doing something called SBRT, stereotactic body radiation therapy, in which a very high dose of radiation is delivered only the prostate sittings, so that the entire treatment is completed in say 5 sittings or 7 sittings, and this gives very high local control. There has been seen that higher the dose that we are delivering to the prostate, the better is the local control in terms of disease, which also gets translated to the biochemical disease-free survival and other parameters that we see. Apart from that, for oligometastatic disease that I was mentioning, now we are very routinely using radiation along with systemic therapy options for local treatment of prostate as well as metastatic sites, and it gives us really good control in terms of progression of the disease at the site where the disease was progressing and PSA was rising, and we are able to continue the same systemic therapy for some more time. So the patient is able to use the same systemic therapy, and the next therapy, which is in reserve, comes into action at a later point in time. So these are some of the very important advancements that are happening in prostate cancer, and definitely technology has really helped us in delivering these high radiation doses regimes.
Thank you so much, ma'am. So we were able to cover multitude of different topics in this discussion, from very technical details to also basic information. But before developing these questions for today's session, we did a very short little poll with our internal team to help make us understand what the general public has doubts regarding prostate cancer. So most of them we were able to cover today. But there are still few left, which I would like to ask Dr. Jyoti. So, ma'am, can you please help us clear some doubts, which is many people feel that prostate cancer could be hereditary, that if their parents, if their father had it, there is also chance of them developing it at some point in life. So, ma'am, can you please clear this doubt?
So it's actually true to some extent. So a small proportion of prostate cancer patients could be harboring defective genes, and they could be hereditary. So up to 5 to 10% of all these cases could be hereditary. So it does make sense to go and get yourself checked, especially the patients for presence or absence of those defective genes if they fulfill the criteria, and be aware.
Thank you so much, ma'am. Another very emerging doubt amongst the younger population was that if I am not paying good attention to my diet and exercise routine, if my body fat percentage is very high, if I have a belly fat, or if my habits include having, beer and other alcohol at least once or twice per week, so am I more susceptible to developing prostate cancer in future, based on my lifestyle choices? So can you please help us understand and clear this?
Who do you want to answer?
Ma'am, you.
Okay, great. So prostate cancer is linked to obesity. So there is a correlation that the risk is greater in obese people. Now, there is some association with diet as well, especially the content of dairy products in the diet. But the main risk factor, which is much more proven with the risk of prostate cancer, is obesity. Now, besides prostate cancer, it's very important, to be aware of all these risk factors, because, say, obesity itself, it not only increases the risk of prostate cancer, but so many others, 7 or 8 more cancers as well. So it's very important to realize the importance of good lifestyle, healthy diet, leading an active life, exercise, to avoid not only prostate cancer, but so many other cancers also, and heart disease as well, and reduce the risk of diabetes. So a healthy lifestyle does make a lot of difference.
Thank you so much, ma'am. My next question is to Dr. Aditi. Ma'am, most of the people have this belief that prostate cancer returns some years after treatment, and it can potentially return. So what would your answer would be to help understand and eliminate bust this myth? Dr.
You want
Aditi?
to understand the risk of relapse. That means the risk of the
Yes.
disease coming back after treatment.
Yes.
Okay, so definitely when there is a malignancy, a cancer detected in a person, we treat that person, and the chances of relapse are the highest in the first 2 years post-treatment. So the patient has to be on follow-up, which has to be 3 monthly with the help of PSA, some imaging in the form of MRI. If required, PSMA, PET is also done. And after first 2 years, then this follow-up becomes 6 monthly, and after 5 years, this would become yearly. And with increasing time that lapses after treatment, the chances of relapse would reduce. But here, what is most important is that you should be in touch with your treating physician. You should undergo your tests regularly. Tests do not help back. Tests pick up the disease early if it is coming back. So we are able to treat it with less aggressive treatment. We are able to treat it more completely. We are able to treat it with lesser side effects. So awareness, again, here is very, very important. Not just for people who are not diagnosed with disease, but also for patients who are on treatment or post-treatment. Their follow-ups with the doctor, their regular checks in the form of blood tests and imaging are very, very important. I can understand that there is a fear, but more than fear, they should be aware that if they are on regular checkups, then if at all it relapses, we'll be able to pick it up early and again get a chance to cure it.
Thank you so much, ma'am. And my next question to all our panelists would be advices. What their key takeaways would be to all the audience that is watching today's show. So starting with Dr. Aditi, as we left off with you.
Okay, so my advice here would be stay aware. After a certain age, say 55, 60 years, your regular PSA monitoring should be done. And if it is serially increasing, then please do see a urologist. If required, MRI and biopsy may also need to be done to rule out cancer. Prostate cancer can be very easily picked up. PSA is a very sensitive marker, and it can be very nicely treated and cured in early stages. Even metastatic disease, we have very good cure rates because of multiple therapies being available which act together. So key would be stay aware.
Thank you so much, ma'am. Dr. Anurag, sir, what would be your key takeaway to all the audience that is watching this show?
Dr. Aditi has already told that screening is very important because we can detect the disease in the early stage only by screening, because symptoms, they appear very late. So all the patients who are more than 55 years of age, they should undergo physical examination of the prostate as well as basic PSA test. And if there is any index of suspicion, they should not postpone and they should go ahead with the further testing, because this disease is very slow growing disease and it has a very good response rate, and most of the patients can have normal lifespan after treatment, even if they are in the little bit advanced stage.
Thank you so much, sir. Dr. Ajeev, sir, very quickly, what would be your key takeaway?
So basically, I would like to highlight one thing, that PSMA PET is not a screening tool for prostate cancer imaging. It should not be, or it should be avoided in patients with low risk prostate cancer. So some of the time you might pick up some metastasis, but many a times it will pick up false positive lesions, and hence your treatment decision will be delayed. So do not do that. So just take the opinions and consider the decisions taken by your clinicians, and then you should go for further imaging. So do not go for imaging as per your will. And several nuclear medicine techniques are also available for prostate cancer patients. So do not get depressed. Unlike other malignancy, in prostate cancer, several treatment options you have: medical treatment, radiation treatment, surgical treatment, and on the top of that you have nuclear medicine treatment. So if you are not able to tolerate chemotherapy, then in those cases you can take help from nuclear medicine physicians and for lutetium PSMA based therapy.
Definitely, sir. Thank you so much. Dr. Jyoti, ma'am, what would be your key takeaways to all the viewers that are watching?
So I want to emphasize again and again that early detection is possible in prostate cancer. Early detection is the way to go to winning the war against prostate cancer. It's very much doable. You just need to be aware that there is an entity called prostate cancer. This is how it will manifest. And therefore, at the onset of those symptoms, go to a doctor, follow the doctor's advice, undergo those relevant tests, get yourself treated. And the treatment is a team effort wherein a lot of us would be giving our inputs. It's not just one doctor who would be taking the entire care of you. Have faith in your doctor and undergo the treatment as per doctor's advice. And obviously continue to follow healthy lifestyle, healthy diet, stay active, and to prevent as well as all through the treatment of prostate cancer.
Thank you so much, ma'am. With that, we come to the end of this very interesting and informative session on prostate cancer awareness. I would like to thank all our dignitaries who have joined us today for taking out time from their busy schedule and imparting with us the wealth of knowledge and information on this topic today. Thank you so much. Thank you, Dr. Jyoti Wadhwa, Dr. Anurag Khaitan, Dr. Aditi Agrawal, and Dr. Ajeev Mishra. Thank you so much. I would also like to thank AstraZeneca for partnering up with us on this very brilliant initiative on spreading awareness around prostate cancer. Thank you so much. And lastly, I would also like to thank all our audience for staying with us till the very end. Thank you. With that, we sign off now. Stay happy, stay healthy. Bye-bye.
Thank you.
Thank
Thank you.